So we have some time for like question and answer, and I think we have a little bit more time than we thought we had. So please just keep writing your questions on the side, and I think Edsel has been answering some of them. So let me just go over some that I think weren't answered. So there's one question. What is the main mode of transmission of COVID-19 in the Philippines and the community? And I don't know how you might interpret that question. And I guess that's for Edsel, if you want to take that.
Yeah, I mean, I think that the evidence shows that it's still respiratory droplet more than anything. The aerosol data is suggestive. We know it happens in the hospitals, especially when we're doing aerosol generating procedures. But again, it can happen in areas with poor ventilation. If the G614 story does bear out that it is more infectious, 3 to 6 times more infectious, then maybe that we're going to see a lot more of this transmission. But most of the time it's still aerosol. Well, I mean, most of the time it's still droplet. What's concerning to me, though, is that we are seeing a lot more asymptomatic transmissions. We had a breakout in our laboratory, and the only reason we found it was because our research associate was going to the province, and they required a rapid test, which we don't really like doing because it's not very predictive, but it was IgM positive. So we went ahead and swabbed him, and it was positive. And we swabbed our whole lab. We had 5 people who were positive, none of whom had symptoms. So it's really strange. I think we're still learning more and more about this virus, and it's really hard to say what works and what doesn't, on top of the fact that the virus continues to evolve.
Okay, thank you for that. So actually, it dovetails into that one question, which I think all the speakers can feel free to answer. Which test would you deploy to open the economy? And I think there's several ways of thinking about that.
Yeah, I mean, I think it's a balancing act. I think, you have to balance the costs versus how accurate it is. I know, I think America would know, and Vince, our undergraduates, they just have testing right recently. Surprisingly, they're going to test them, several times a week. I suspect that's going to be PCR testing to see whether you pick the positivity. That's a lot of, resource put into having schools kids going back. So there must be a better, efficient way to do it. And so I've already heard a lot of comments about that decision. And so the antibody test is ideally would be good, but I think it hasn't been shown to be highly reliable yet, and to see whether there's any reinfection despite having antibodies. So I think those studies still need to be done, right? And so I think it's really having careful social distancing, mask use, being careful.
Any thoughts?
Maybe I'm just going to add. I mean, very early on, a lot of us were kind of aghast that WHO said test. Because part of the problem here is that our tests aren't perfect. They're 62% sensitive for an NPS on the day of symptoms. After 3 days, it's 80%, and then it's lower than that afterwards. So there's really no good way to pick up everyone. And if 40% of people are asymptomatic, what does that tell you? So someone's going to get through. And we've been pouring so many resources into testing. And even if you get that test back in 24 hours, you could actually get infected the moment you walk out of the lab. So it doesn't make any sense that there's so much focus on testing when we should be putting resources into isolation, into contact tracing, into making sure that everyone is wearing their masks, and in technologies that can further prevent transmission. So I think it's all misguided. It's particularly bad for resource-limited settings, because we've been pouring all our money into these molecular tests that aren't perfect and acting like we could test our way out of this pandemic. We can't. It's not going to happen. So the best thing to do is to put resources into taking care of the sickest people and make sure that they survive. We need to reinforce our healthcare systems, which are woefully already inadequate at normal times. And so we can't take care of COVID patients. We can't take care of non-COVID patients. That's where the deaths are going to come from. It's not all these 80% mild people that are going to get better on their own. So I don't think that you should even try, or it's realistic to test everyone that you think should be tested. I think we should really prioritize our tests and put the tests back in the hands of the doctors rather than on the policymakers who are just deploying it without knowing what it does, and missing a lot of false negative cases and generating a lot of false positives. So that's my soapbox. Sorry about that.
No, that definitely makes sense. So I think we'll go to the next question, which I think also will generate a lot of answers from you guys. So for all three speakers, could you describe how a surveillance program should work? Like how often should you test if you're actually surveying? Where it's that whole concept of, is it that every 2 weeks? Do you do it when people are just symptomatic? What are your thoughts on that?
I mean, I think it's still the same thing, right? I mean, it's if you want to know, like in the community, how prevalent is the virus, and or like do you have a mutation, for example? You kind of you have a solution to what to do with that information, right? And so I know I mentioned about the sewage testing just to get a sense of what the community has and when will be another rise, but if even if knowing that information, you don't have a good sort of public health prevention, it's not going to help anybody, right? So, and so I think it's still unclear. I don't know. Other folks have any other additional thoughts?
Yeah, again, the issue really is, again, when you walk out of the lab, even if your test is negative, you can get infected right away. So there's no way you can capture all these. I know some hospitals are testing every 3 days. The NBA is testing every day. That's a little bit much. But again, who needs a test? If they're healthy and they're young, the issue really is you're not testing to treat them, because if it's mild then it's not a big deal. You're testing so that they don't spread it. So if you prevent the spread with masking, social distancing, and everything, then you mitigate the problem of having to test all these mild people. And even if you test all these mild people, there's going to be 40% or more walking out there who are going to test false negative anyway.
Okay. So with that question, Edsel, the question is like any seroprevalence study being done in Manila right now?
Yes, actually, former Secretary of Health Manolet David is doing seroprevalence. They initially were using rapid tests, which we know some of them turn negative after a few weeks because of lower titers. And I think they're trying to supplement that with ELISAs. I haven't seen the final data yet, and I don't know how they sampled. Anecdotally, the city of Manila started doing CLIA testing on people, and they tested about 4,000, and of course these were self-selected. It's not a random sample, and about 600 were positive. So yeah, that's a fairly good number. So we'll see. But again, I don't know how that's sampled. I mean, those could cluster in households as well if you have full households getting tested.
Okay. And then maybe Maricar, I think this might be for you. So what role would monoclonal antibodies play in treating COVID-19?
Yeah, so actually this morning we found out that kind of disappointing result from this tocilizumab clinical trial. I guess, my colleagues and I are a little bit biased because we think that, based on our local experience that, and based on our local data, that we think that it may have helped. I think, the use of this immunomodulator really depends on when you actually initiate it. When you initiate it very much late in patients who are already critically ill and mechanical ventilation, it's almost like the cytokine release storm has already hit like so hard that there's no way of almost like reversing it. So I think our approach of what we have done when we have given it early, we believe that it actually helped in preventing patients getting intubated. So, but I think in the total scheme of things, in terms of like treatment approach, I think it's really a multimodal approach. It's really a combination of antiviral, if given early, and kind of giving this immunomodulator at the right time. And sometimes, like, you know, the right time, when is that? It's kind of pretty golden.
Mhm.
So one of the, actually, our experience has been using CRP as a good predictor. It's almost like you can see the pattern of the CRP going up and the O2 requirement going up, and then you kind of hit them with you know, with tocilizumab. But currently our approach has changed because we have to follow what the data tells us, which is actually now we shifted to the use of steroids. So we are actually in the process of evaluating, you know, our experience too, based on the combined approach of the remdesivir and the tocilizumab, and also look into our data, because initially we have used also steroids in a reverse fashion, wherein we hit toci first and dexamethasone after, or any glucocorticoids afterwards. So those are, you know, it's not a randomized control study, which is the ideal setting, but during the early days of the pandemic, obviously, you know, we didn't have the infrastructure to carry out any of these studies.
Yeah,
Sorry,
I second the motion. I love tocilizumab. I
I
mean, it's
know.
worked really well for me as well. But aside from tocilizumab, which is an IL-6 monoclonal antibody, the one that I'm really excited about are the direct monoclonal antibodies against the virus, monoclonal antibodies against the
That's what I was
virus.
thinking.
And I think also they're thinking about combining them. And the one that we have the most experience with, well, not personal experience, is HIV. And we know that the broadly neutralizing antibodies in combination do work. So there is some proof of concept in that sense. And the nice thing about these antiviral monoclonal antibodies is that they're going to have long half-lives. And so they're kind of, you could use them as a bridge, as like passive immunization, particularly for our healthcare workers. If they do work, then let's give them to our frontliners, because then, you know, they'll be protected maybe for a month or 3 months at least until the vaccine comes out. And it's almost a bridge to the vaccine in that sense.
Okay, so I'll probably keep it to one or two last questions, but there's one where, any comments about the herd immunity that seems to be happening in Mumbai? How was our seroprevalence testing going on the country sponsor? Oh, well, that was the same. Okay, but what do you guys think about the herd immunity in Mumbai? Is that possible, actually?
I think we know too little about it. We also don't know if these are neutralizing antibodies or non-neutralizing antibodies,
Mm-hmm.
and how long they last. And the more important, as has already been put in Nature and all the other papers, is T-cell immunity, because that's what really has an antiviral effect.
Okay, and then the last one, this will be an easy one. And this will be more of like, what's your opinion? So which country is doing the best job of isolating and minimizing the impact of COVID-19? I say it's America, actually. So you guys can take your pick of the other ones left.
Yeah, I think it's too early to tell, because I mean, even the best places like Taiwan and so Taiwan, South Korea, Japan, Australia have had secondary outbreaks. Hong Kong is in trouble right now, and we did okay initially. And the initial, you know, you can see if you go back to the by date of onset of our cases in the Philippines, the ECQ really did bring the cases down. Unfortunately, now that we open up, and then maybe the increase, so it's very difficult, because each country is unique. It has its own dynamics. You know, like Manila, Mumbai, those are people in very close settings. I mean, you look at Singapore; they had a good response initially, and then they had an outbreak among the immigrants who were in close quarters. And you know, it only takes one, and this virus is an infectious disease. So I'm not gonna write any report cards at this point, because we are far from over.
Yeah, I mean,
Okay.
I agree, because I think in the Northeast we initially had the big spike, right? And now we're on the bottom, which is hopefully will keep, but we're not like going to celebrate yet, because we're worried about another increase. And some people say it might come in August, as you know, some of the students come back, and we have hotspots in other parts of the country. And so this is not, I agree, this is not over until I think we have a good vaccine and people follow the preventive rules. So.
Okay, so I think at this point, a few questions still came up. What we can do is like maybe the speakers can just look at it and then just try and answer it like written down. And I'll give the floor to Vince again for the next session.
Maima, thanks for moderating the Q&A. A question came up. I'm really interested what our folks think about this. Success with convalescent plasma. Maricar, I'll put you on the spot.
Yeah, so I think it's too early to say. I think just based on our local experience, it's hard to tell because these patients have already been hit hard with so many agents, and then they will get the convalescent plasma on the very latter stage. So we don't know exactly if the convalescent plasma really did help,
Right.
or maybe this is just basically the patient's immune system recovering on its own. So I think our local experience was kind of equivocal, I would say. So I think we're still waiting for that clinical trial to really show whether it's beneficial or not.
Yeah, I
So what's
agree.
experience? Yeah. Go ahead.
Yeah, it's kind of hard to say also because each patient is unique. Their titers are going to be different. We don't know what proportion of it has neutralizing antibodies, and on top of that, these are really hard to control because you're not going to give a sham convalescent plasma to anyone. It's not going to be a nice randomized trial. So yeah, it's really tough.
Okay, so thanks everyone. Thanks for our first three speakers. So we have to move things a little bit. Our next speaker isn't around yet. He's a pulmonologist, and I don't know whether he got stuck with, hopefully not with a COVID patient. But we're gonna skip him for now. We're gonna move on to our 9:20 talk, which is almost just in time.